Welcome to our video on Cushing syndrome. Let's get started. Here is our overview slide. We'll be discussing the definition, etiology, pathophysiology, clinical features, diagnosis, and management. Let's start with the definition. There are two similar definitions that are important to understand as it pertains to this condition. The term Cushing syndrome refers to a clinical state of glucocorticoid excess regardless of the etiology. The term Cushing disease, on the other hand, refers to a clinical state of glucocorticoid excess specifically due to an ACTH producing pituitary adenoma. Although clinicians may use these two terms interchangeably, examiners are usually more intentional in their wording on tests. For the purposes of this presentation, we'll be referring to this pathology as Cushing syndrome because the term Cushing disease is also a type of Cushing syndrome. There are several notable etiologies of Cushing syndrome. First is chronic glucocorticoid use that, for example, may be seen in organ transplant patients receiving steroids to avoid rejection of the transplanted organ. Second is adenoma, hyperplasia, or carcinoma of the adrenal glands. Third is an ACTH-producing pituitary adenoma, which is Cushing disease. And fourth is a paraneoplastic syndrome, which leads to excessive production of ACTH. This is most commonly tested in the context of a small cell carcinoma of the lungs. The pathophysiology of Cushing syndrome has to do with the downstream effects of excess cortisol in the body. The most notable effects include insulin resistance, impaired cellular immunity, and impaired wound healing. There are several notable clinical features that are common among patients with Cushing syndrome, all of which stem from high levels of systemic cortisol. Due to cortisol-induced insulin resistance, the body secretes a lot of insulin, which causes excessive deposition of fat around the abdomen, leading to central obesity, around the back of the neck, leading to the so-called buffalo hump, and around the face, leading to the characteristic moon facies. Cortisol also ramps up gluconeogenesis, a process that utilizes amino acids that the body supplies by breaking down proteins within muscles, and this leads to muscle wasting, weakness, and the characteristic thin extremities. Finally, cortisol interferes with collagen synthesis, which disrupts wound healing, leading to the thinning of the skin and easy bruising, and produces the characteristic purple striae on the abdomen and extremities. Here's a graphical illustration of what patients with Cushing syndrome may look like on physical examination. In question stems, examiners will often describe the presence of fat pads, multiple bruises, abdominal striae, and thin arms and/or legs. Here's an image of a person with Cushing syndrome that depicts the characteristic moon facies. Once again, moon facies refers to excessive deposition of fat on the sides of the face, leading to a rounded appearance. Here's an image of a different patient with Cushing syndrome that depicts the characteristic purple striae that can be seen in this condition. In addition to the high-yield clinical features that we just discussed and saw, there are several others that are worth mentioning. These include hypertension, osteoporosis, immunosuppression, psychiatric symptoms such as anxiety, and in women, amenorrhea, hirsutism, and even virilization. Once again, most of these changes can be explained by the downstream effects of elevated serum cortisol levels. However, for the purposes of step 2, it isn't important to know any of those specific mechanisms. When it comes to the diagnosis, it's best approached using a simplified diagnostic algorithm. When a patient presents with signs and symptoms of Cushing syndrome, such as a buffalo hump or abdominal striae, clinicians may choose one of 3 available tests to initiate the workup. These tests include a 24-hour urine cortisol level, a late-night serum or salivary cortisol level, and a low-dose dexamethasone suppression test. Let's examine each of these in greater detail. A 24-hour urine cortisol level is usually the first-line screening test of choice when it comes to the workup for Cushing syndrome. This test is considered positive if the urine cortisol level is greater than 3 times the upper limit of normal. A late-night serum or salivary cortisol level is obtained to assess whether the patient has physiologic or supraphysiologic levels of cortisol at baseline. Normally, cortisol levels should be close to 0 when it's late at night. Therefore, if this test reports an elevated level of serum or salivary cortisol, it would be consistent with a diagnosis of Cushing syndrome. A low-dose dexamethasone suppression test is considered to be the most sensitive test for Cushing syndrome. In this test, the patient is given dexamethasone in the evening and their plasma cortisol is measured the following morning. Since dexamethasone is a steroid, it should suppress ACTH production and lead to decreased serum cortisol. In patients with Cushing syndrome, however, this will not happen and the cortisol levels will remain elevated. Therefore, this test is considered positive if plasma cortisol measures at greater than 5 micrograms per deciliter the morning after the patient receives a low-dose dexamethasone suppression test. Once the diagnosis of Cushing syndrome is established, clinicians should obtain a serum ACTH level to further delineate the most likely etiology. If the serum ACTH level is low, that means the patient has an ACTH-independent form of Cushing syndrome. In this category, the likely etiologies are an adrenal tumor or use of exogenous glucocorticoids. If the serum ACTH level is normal or high, on the other hand, the patient has an ACTH-dependent form of Cushing syndrome, which means the high levels of systemic cortisol are a result of high levels of ACTH. The next step is therefore to identify the source of the excess ACTH, which can be accomplished with a high-dose dexamethasone suppression test. If, following the test, serum cortisol is suppressed, that is, serum levels decrease, the likely etiology of Cushing syndrome is an ACTH-producing pituitary tumor or Cushing disease. If, on the other hand, the serum cortisol is not suppressed, then the likely etiology is an ectopic ACTH production, which commonly occurs as a paraneoplastic syndrome of lung cancer. Once all of the laboratory workup is said and done, clinicians may also order appropriate imaging studies. For example, an abdominal CT to further work up a likely adrenal tumor, or a brain MRI to further work up a pituitary tumor. Here's a sagittal brain MRI of a patient with a large pituitary tumor. By means of orientation, here's the spinal cord, the medulla, and the pons. And just anterior to the pons and under the hypothalamus is this large circular mass, which represents the large pituitary tumor. If Cushing syndrome is caused by chronic intake of exogenous steroids, management involves tapering steroids where possible. In other cases, management depends on the exact etiology, but usually begins with temporizing measures to control the condition prior to definitive treatment. For example, clinicians may use adrenal enzyme inhibitors such as ketoconazole or midotate or glucocorticoid receptor antagonists such as mifepristone in order to mitigate most of the effects of elevated levels of serum cortisol. Most patients will eventually be scheduled for surgical resection of their tumors, be that adrenal tumors or pituitary tumors. Following resection of those tumors, patients usually will require post-operative steroid replacement, as it may take a while for the body to resume normal ACTH or cortisol production following surgery. All right, let's try a question. What are the key similarities and differences in the clinical presentation of Cushing syndrome and polycystic ovarian syndrome? All right, Cushing syndrome and polycystic ovarian syndrome, or PCOS, have several overlapping clinical features, which is why they can sometimes be confused. The key similarities include obesity, amenorrhea or hypomenorrhea, and signs of androgen excess, for example, acne. However, only Cushing syndrome leads to muscle wasting, abdominal striae, and easy bruising, which helps distinguish it from PCOS. All right, let's wrap up with the final question. A 28-year-old man presents to clinic to discuss weight loss. He says he's been gaining weight over the last 6 months despite strict adherence to a diet and exercise regimen. He says he used to feel self-conscious about his weight, but more recently he has been experiencing severe anxiety regarding his weight. Blood pressure is 163/98 millimeters of mercury, pulse is 75 beats per minute, temperature is 36.9 degrees Celsius, and the BMI is 35 kilograms per meter squared. Physical examination is notable for thin upper and lower extremities, truncal obesity, and purple stretch marks on the abdomen. The initial laboratory evaluation is notable for a normal serum TSH. Which of the following is the next best step in the diagnosis of this patient's likely underlying condition? A. Morning serum cortisol level. B. Low-dose dexamethasone suppression test. C. High-dose dexamethasone suppression test. D. Serum aldosterone to plasma renin ratio. Or E. Serum ACTH level. All right, the correct answer is option B. Low-dose dexamethasone suppression test. This is a case of a 28-year-old man who has been gaining weight over the last 6 months despite a diet and exercise regimen. Notably, he also reports recent episodes of severe anxiety. He has hypertension and an elevated BMI, and his physical examination is notable for thin extremities, truncal obesity, and abdominal striae. Given this information, the patient most likely has Cushing syndrome. Recall from this slide that patients with Cushing syndrome often present with central or truncal obesity, as well as thin extremities and purple striae on the abdomen. And recall from this slide that these patients may also sometimes have hypertension and psychiatric symptoms, such as anxiety. Recall from our algorithm that when a patient presents with signs and symptoms suggestive of Cushing syndrome, clinicians may order one of 3 available tests, including a low-dose dexamethasone suppression test, which was the correct answer for the question. So if we return to the question, we can see that option B, low-dose dexamethasone suppression test, is the correct answer. Option A is incorrect because this test is used in the diagnosis of primary adrenal insufficiency, not Cushing syndrome. Remember, it's the late-night serum cortisol that can be used to diagnose Cushing syndrome. Option C is incorrect because this test is used to delineate the etiology of an already confirmed Cushing syndrome. Recall from the algorithm that a low-dose dexamethasone suppression test can be obtained as part of the initial workup to diagnose Cushing syndrome, whereas a high-dose dexamethasone suppression test is used to figure out whether an ACTH-dependent form of Cushing syndrome is due to a pituitary tumor or due to ectopic ACTH production. Option D is incorrect because this test is used in the workup of primary hyperaldosteronism, not Cushing syndrome. Although this patient's elevated blood pressure could be consistent with primary hyperaldosteronism, his thin extremities, truncal obesity, and purple stretch marks are more suggestive of a diagnosis of Cushing syndrome. Lastly, option E is incorrect because this test is used either as primary workup for primary adrenal insufficiency or to determine whether an already confirmed case of Cushing syndrome is ACTH dependent or ACTH independent. So again, the correct answer is option B, low-dose dexamethasone suppression test. And that concludes this section.